Hi, how are you doing?
They must be with you. The only rational path. Yes.
We should have quorum now.
rules say I'm allowed to use the gavel for starting and ending. I'm going to do it. I would like to call the meeting to order. Members of the public are advised that our meetings are webcast live by the City of Hamilton and temporarily archived on the city website. Other individuals and the media may also be audibly and or visually recording the meeting. As well, a reminder that all electronic devices are to be switched to the non-audible function during committee meetings. Madam Clerk, are there any changes to the agenda?
Through you, Mr. Deputy Mayor, no, there are none.
Great. May I please have a motion to approve the agenda as presented from Councillor Van Der Beek and Mayor Fred. All in favor? Fabulous. We are moving on. Item 3.1, which is really all we're here to do, and it's a privilege to introduce our speaker and presenter today. I would like to call upon Rob McIsaac, President and CEO of Hamilton Health Sciences, to provide his presentation, which is item 3.1. Welcome and thank you.
Mr. Deputy Mayor, my apologies. We need to do declarations of interest first, please. Okay.
Any declarations? I see none, so moving on. Mr. McIsaac, the floor is yours.
Thank you very much, Mr. Chair. Really pleased to be back, and you'll recall this meeting is sort of the outfall of a prior presentation where the Mayor expressed some interest in doing a deeper dive into the process that we've been following, and so we're very encouraged by the interest of Council, and pleased to be back. I brought my posse with me this time, Mr. Chair, just in case I get into trouble up here, which isn't completely unthinkable. So on the far left is Dick McLean, who is our EVP and Chief Medical Executive, Brenda Flaherty, who is our Chief Operating Officer, Dave McCaig, who is our EVP Corporate Affairs and CFO, Sharon Pearson is there. She's our VP of Community Medicine and Population Health. Aaron Levo is up in the second row. He's our VP of Public Affairs. Cynthia Jansen is here. She's our Manager of Stakeholder Relations. And Fran Agnew, who is Director in the President's Office. So we're all very pleased to be here. So lots of intellectual horsepower up there in the gallery, Mr. Chair. And if you have questions for them, I know they'd be delighted to come down. So this is, I guess, a little unusual because it's a single-purpose meeting, but the way we're proposing, with your consent, Chair, to deal with this would be to divide the presentation into 4 sections. We'd start with just a little overview of the capital planning process in the health sector, move on to our vision, then with respect to our patients and population health, talk a little bit about the role that we play in the community as section number 3, and then finally the last topic is, well, how will our physical form ultimately match the function that we started talking about. So, I'll stop after each one. We have, in this process, been out on the road for quite some time now, trying to get as much interest as possible in what we think is a really important initiative in terms of the future health of the city. You can see the icons for the various stakeholders that we have in different ways tried to connect with over the course of our consultation. And we've been really encouraged by how many people have dug in. So where we are right now is called stage 1A of the planning process. So that implies that there's many more stages to come. So we really are at the very start of this process, but we are looking ahead 5, 10, even 20 years at the volumes we can expect and the nature of care that we think we're going to need to deliver to this community. And then we will ultimately develop facilities to make sure that we're matching the services that we provide. That means that we have to create a vision for our clinical services. It also is an opportunity for us. As you know, our history is we are a collection of amalgamated entities. And over time, for sure, we've continued to act more and more like a system. But this is definitely a process which is oriented towards us taking more of an enterprise approach, a systems-based approach using systems thinking as we redevelop Hamilton Health Sciences. So the next stage, which we will start on this fall, We'll talk more about how our programs and services work together, the role of individual facilities. Today and tomorrow, we'll be looking at long-term options for siting and thinking harder about new models of care. Just for some context and to, I think, reinforce the importance of the process, our last capital plan was done way back in 1989, and the outcome of that planning process was a redeveloped Juravinski Hospital and Cancer Center, the West End Urgent Care Center, our regional rehab hospital, our research institute, and also the Ron Joyce Children's Health Center. So I think, it's important for us to get this right, because ultimately there'll be many dollars spent in terms of implementing this plan. We recognized at the outset that there are a number of real challenges and opportunities facing healthcare for us here in Hamilton, and I'll dig into that more in a minute, but we know we have amongst the highest urban hospital use of any community anywhere in Ontario. We're also dealing with an aging infrastructure. Lots of our buildings are getting close to the end of their useful life. We've got some buildings at the Juravinski and the General in particular, which are many decades old. We also know that the population of people aged 80 plus is going to double in the next 25 years, and we know that it's not a perfect correlation, people do start to use the hospital more the older that they get. The other thing is the rise in chronic disease. So we're seeing lots of people living longer, but also living long enough to acquire multiple chronic diseases. So we are getting more business, and the business we're getting is more complex. This is an interesting chart because it really shows, it takes age out of the equation. So it standardizes for age, so that you can't say that our community is older than another's older than ours, and that's why the hospital use is where it is. So the data has been basically scrubbed for that factor. So that's along the y-axis, so the y-axis is hospital use per 1,000 people. The x-axis is population. And you can see the red circle up there, Hamilton's urban core. It is bested only by places like Thunder Bay, Cochrane, Kenora, Temiskaming, and those are generally places that have no other facilities other than their hospital. So people have no choice but to go to the hospital in those communities. But it gives you a sense of the extent to which Hamilton's urban core uses our hospital facilities. So it's quite an extraordinary thing from our perspective, and drives so many of the metrics which are important to us. In terms of our planning timeline, we will take the plan that this Phase 1A to our board in June of this year for approval. In September, we will then remit it to the LHIN. The LHIN board will consider it early in the fall. It will then be forwarded on to the Ministry of Health and Long-Term Care. We will then get to work on Stage 1B, and we anticipate not being finished that in any time less than and then after that, we will get into very detailed functional planning where you actually bring in architects and so on to start to really flesh out the vision. So I'll pause momentarily there on that process point before I carry on any further, see if there are any questions.
Councillor Jackson.
Thanks, Mr. Deputy Mayor. And for the record, President McIsaac, thank you very much. I think I was one of several members of council who said that last time you were here. 7 minutes just wasn't sufficient enough to outline a 20-year plan. So thank you for coming back. Much appreciated. So, Rob, just to be clear, Ministry of Health capital planning process. So this is driven by the ministry to various jurisdictions in the province saying financial trouble, potential challenges on the horizon, review exactly your portfolio, similar to what our community went through with the healthcare restructuring task force of the late 90s, or is this a little process-driven different? Through you, Mr. Deputy Mayor, please.
Thank you for the question, through you, Chair. This is a standard process. It is not being driven by anything in particular. It is simply the process that every hospital in the province has to go through as it thinks about redeveloping and renewing its capital. So I would say it's more like the city's official planning process than it is like a special restructuring commission. So it's something that every hospital would be expected to do on a somewhat regular basis.
Okay, thank you for clarifying that. Can you just go back, Rob, a couple of slides, please, where you say the last capital plan completed in '89? That slide, please, right there. Rob, is memory serving me wrongly? I thought the Juravinski Hospital, when this community decided to save the former Henderson Hospital in the late 90s, again through that very controversial healthcare restructuring task force by the provincial government of the day, I thought we rebuilt that in 2000, early 2000s. Through you, Mr. Deputy Mayor. Am I missing something here?
No, I think I'm just trying to make the point that everything you see there was actually envisioned back in '89 during that capital planning process. So those redevelopments would have fallen out of our last last capital planning process, which took place way back in '89.
Oh, so the word process, if you will, would have been up there. Last capital planning process completed in '89.
Sure.
Gotcha.
Yes,
Fair enough.
apologies.
Fair enough. Thanks for that clarification. Thanks, Mr. Deputy Mayor.
Pardon me. Thank you. I have no further speakers on my list. So, Mr. McIsaac, please continue.
So as we think about how life is going to change moving forward, I think one of the big moves, the bold moves that we see is that the role of our patients is going to change. And whereas I think previously people would show up at the hospital, there would be treatment, they would be discharged, maybe admitted, and then discharged. We really think that both in terms of what the public's expectations are and the way that we will need to ultimately get to is patients need to be seen as partners in their care. As we went out and talked to the community, everybody assumed that they would get top quality care whenever they showed up to the hospital. It's an extraordinary thing as somebody in a provider role because we work so hard. Everybody gets quality care. It is an extraordinarily difficult thing to do, and we have such great doctors, such great staff. We think by and large we are able to meet that standard, but it is not something that we can ever assume and something that we have to work at really hard. From the public's perspective, however, they assume that they're going to get that. I think where people are starting to think a lot more these days is in terms of the experience that they get. So they want their family involved when they come into the hospital. They want us to treat not just them, but their family as part of the care unit. They want to feel like they have an advocate when they come into the hospital so that somebody is there acting as their champion at all times. They want to have somebody, they want the system to be easy to navigate, and where it's not perfectly easy, they want assistance with that navigation. And they want to feel respected. They want to be treated with dignity. And so those were all very strong themes that came through for us as we were out on the road talking to people. So looking forward, our vision really is to see, rather than an episodic kind of relationship with our patients, a more enduring relationship. We think that, we need to stay in touch with our patients long after they've left the hospital. In fact, we need to start thinking about, can we start getting a hold of people even before they show up to the hospital, and if we can, try to cause a bit of a course correction so that they don't end up coming to us. So our relationship should not be episodic or transactional. We also think it needs to be collaborative. Our patients need to be engaged and activated in determining the whole of their own health. So people will not be satisfied simply being told what to do. We need to be thinking lots about how can we interact with people in a way that activates them to actually start to really positively engage with their care journey and their own health. Those are really two concepts that are underlying what is known in medical circles as a population health approach. And so this pyramid really gives you a good idea of what a population health approach is. It involves looking at our whole patient population and starting to stratify that population, thinking about people at the bottom, low risk or predictable path patients. The hospital strategies generally around those patients are just deliver really great service, get them in, provide quality care, great experience, and hopefully discharge them as soon as responsibly possible. The rising risk patients are the kind of patients, think of somebody who's sort of 54 years old, diabetic, drinking, smoking. We know, they might be here today because they need a few stitches, but when you look at the whole person, they're on a journey that's probably going to see them landing in the top of this pyramid, which are people who have multiple chronic diseases and who end up using our services a lot. So the strategies around those rising risk patients, if you can identify them, is very much about what I was saying earlier, engage and activate and partner with those people and try to get them on a different path so that they don't become those high user patients at the very top. For the patients who are at the top, it's not that we can, it is what it is to some extent with those folks. It's really about trying to help them manage their disease and to have a reasonable quality of life. And so we need to think about new kinds of strategies to help those folks better manage their disease out in the community, avoid crashing and showing up in our emergency department. So just by way of example, we've done some of this work, and we know that the top 5% of our patients, the 5% of our patients who use the hospital the most, are driving almost 60% of our costs, which is an extraordinary graphic from my perspective. So you can imagine, if we can find new strategies to help these folks better manage in the community, there's a lot of potential freeing up of resources within the healthcare system. If you just look at the top 1% of our patients, about 1,000 people, about $76 million in costs for us. So I can pause there briefly.
Will double in 25 years. In one of your slides just recently, you mentioned involvement of family
and more. Somewhere else and run, the calculation gets a little complicated, but let's say today maybe 13% of all of our beds. If you just look at our acute care beds, it's higher. It's higher.
Okay, and my second question on top of that is hospice care. So again, you just said 13%. That could probably include some of those that are just nowhere else to go and are just too medically fragile to be at home. My understanding is hospice care is about a third of the cost of a patient taking up a bed in the hospital. Is there any room for the hospital to partner with hospice care, or at least, move some of the funding into hospice care, freeing up this 13% that you're stating, but also to get bigger bang for the buck because their staffing is not the same as in a hospital. Their staffing is just to take care of the immediate problems. Is there any indication that they're going to go into that direction?
So hospice care would be one of a multiplicity of partners that we would be looking for as we think about how we can implement this broad-based population health strategy. I just hasten to add, we do provide palliative care within St. Peter's, and we've got such wonderful staff who are doing that. But you're right. Beyond that, we will for sure be also thinking about how we can partner up with many different community partners, and hospice and palliative care will be one of them. So that is a conversation that I think the community really needs to start. This end of life, and how are we going to deal with it as a society? because we aren't doing as well as we need to do today. Too many people are dying in hospital.
And thank you for that. And it is almost two different animals, if you will. A hospital is to help you make you better. So hospice care is to help you with the situation that you're in. So it is two different. It's the same but different. So and the medical staff required is as you know, it's altered. So I was just wondering, because I think we've all had around this table some sort of experience with a hospice or know of somebody. So we know that they're not underutilized for sure. They're probably waiting lists. So that's where my questions were coming from. And given the fact that our population is going to double for our 80-year-olds and more, it just really worries me because I'm getting there, and I just want to make sure it's okay when I get there. So,
Yeah. Well,
I've already pre-booked.
the baby boomers have pretty much dominated every era that they've lived through. So I expect as they're getting older and starting to think about death, the baby boomers will start to drive lots of discussion.
Break it down like that. And I'm sure you might have mentioned this, but if you could care to expand on the prevalent role of mental health in particularly in the emergency care service, and if perhaps its relationships to our RCFs, what impact does that have on our high usage, frequent flyer type care?
I might actually need to ask Sharon Pearson to help me with that statistic.
While she's walking down, I've heard anecdotally of this flip-flop between some of the high-needs residential care facilities and our hospitals in kind of a back-and-forth dance that happens often. And I'm wondering, out of that 5%, what does that look like?
So to answer your first question, if St. Joe's were answering and they were looking at their top 5 or their top 1, they'd say there would be a high prevalence of significant mental health disorders. What we found in looking at our top 5% is we see a lot of depression and anxiety in our population, so not discounting as a mental health diagnosis, but more associated with the number of comorbid chronic conditions that they have. So leading to isolation and not being able to get out and have support. So then we see the anxiety and depression. So not as prevalent in that mental health cohort.
Of course, because they would probably be triaged and sent to, yeah, I completely understand. I was there for childbirth, not in that, but still can appreciate the different expertises that each hospital brings. My next question, Mr. Deputy, through you, Mr. Deputy Mayor, is as it relates to this idea of what place-based care or hubs. The idea of kind of getting to people where they're at, and I know particularly to some of our seniors buildings, just having a City Housing Hamilton meeting now, what's in the future for that model of place-based care or the hub model?
So I think our vision, and I'll talk a little bit more about this as we go further and talk about how our physical approach to delivering care will change, but we definitely see a vision which is really about a hospital sort of without walls, where we have lots more partnerships, a la, Councillor Johnson's question, with a variety of different care providers out in the community, engaging a lot more with civil society, and having Hamilton Health Sciences either partner up in the context of a community hub with other providers, or even have some of our own clinics out in the community. If something doesn't have to be in a hospital, then we think we should probably push it out because it's the most expensive space there is. So it's a kind of virtuous cycle because it's less expensive to get it out of the hospital, but better for the community to have it closer by. So that will involve thinking about the demographics and the in terms of age, but also in terms of income and health demographics of various neighborhoods in the community, and trying to most appropriately partner up and create hubs within those places to serve those local communities.
Excellent. I know in examples, anecdotal examples in our community where this has been experimented with or piloted, I think it's had fantastic outcomes, and so I certainly look forward to seeing that evolve. And, I'll save the rest of my questions for the other appropriate
Okay.
segments.
Thank you, Councillor Green. We move on to Councillor Conley.
Thank you. preventive maintenance, we do that a lot with our cars and everything, but I don't know, do we do it a lot with our health? And I'm suggesting, and that's just, when you're 65, you should have a real thorough examination, check your heart out, check this,
change
check
the oil.
That. It's like a preventive maintenance program, and I don't see that happening a lot. It might be, but I know I'm over 65. I haven't had anything like that. Well, I shouldn't say. Anyways, it don't matter. Do we look at preventive maintenance and how that could save hospital time, surgeries, et cetera, because we're being ahead of the game?
Yeah, I do. So I think that, the earliest gatekeepers in the healthcare system are family doctors in the primary care system. And I think our vision looking forward is very much about trying to achieve a better, stronger relationship between the hospital and primary care, because they play such an important role, just as you're saying, out in the community. So those family doctors working with us, because we can bring a lot to the table in terms of identifying, as I was saying earlier, those rising risk patients, working closely with primary care to try to do exactly what you're saying, either to, course correct somebody who's not doing the right things, identifying them, trying to intervene, develop a relationship with them and their primary care provider in order to try to avoid those people getting into that high risk, high use category. So I think you're right. That's exactly where the focus has to be going forward, because if everybody ends up as a high user, then we will quickly go bankrupt.
Right. Thank you. And the other thing is mental wellness. I know in the last few years, it's not that it's become more serious, but it's become more public, I guess. We're seeing it more, we're hearing about it more, and what we can do. And fortunately, it's not just the hospitals that have to take care of it, but social work and support groups, housing, and we just see a big a situation that is, you almost don't know where to start tackling it from. But are the hospitals working with housing providers and support groups and housing and all this stuff? So we have there's no use treating somebody at the hospital and say, okay, bye, and they're out in the street again.
Right.
So when you look at planning for care, is it total planning, or is it just you're just looking at your sector of what's happening?
So I think that it's a great workplace, and I think that could have a very nice impact on the bottom line for lots of companies as they promote resilience. We in the public sector have to be doing the same thing with our own employees and having wellness programs, including, mindfulness, mental health wellness programs for our employees. So we are, for sure, thinking about mental health. Admittedly, for us at Hamilton Health Sciences, as we've rationalized services within the hospital sector, St. Joe's takes care of mental health, mental illness for the adult population. We still handle the youth population, children's at our McMaster Children's Hospital. I also think the HALE group that the city manager and others, anchor institutions around the city, we have been thinking lots about exactly those issues, about how the interactions between the various public sector institutions who are sitting around that table can come together to tackle challenges like mental health.
I think you could save a lot of money in the long run by doing that, by working together, but it's going to take money to do it.
That's true.
Thank you very much.
Thank you.
Thank you, Councillor Conley. Our next is Mayor Fred.
Thank you, and Rob, thanks for coming back. I appreciate the, I think, higher level of detail that we can get through this presentation. And two questions for you. One is, it follows on what Councillor Conley was talking about, was the interactive kind of work that we kind of need to do, because, I mean, you're talking about patient care. I mean, your first kind of reaction to care or people is when they come to you as a patient, and public health, which is kind of the city responsibility, at least at the moment it is kind of separate and apart from that. It's not necessarily an integrated process. And so we're continuing to promote public health and good health, and also increasing. Is that a reasonable statement to make?
Well, of course, coming from you, Mayor, everything you say is reasonable by definition.
No, not necessarily. Don't ask these folks that. Yeah.
So let me ask, the first question, I think, again, I would point to Hale as an early example of us coming together to start to try to think differently about how our silos are impacting on each other. And I think there are lots of directions that can ultimately come out of that, but they all need to lead to a place where we are acting more in concert with each other and understanding how you spending another $1 in public health might actually save us $2 in healthcare. And so, I think there's lots more work that can be done, and lots, all with a view to having a healthier population. I think the answer to your second question is really, it depends. It depends on the neighborhood. So I guess I would say, and Donna Cripps could probably comment on this better than me, but there are healthier communities in Ontario than this one, just looking at the averages. But it doesn't help that much to look at the averages, because you can drown in a river that's on average an inch deep. So I think the key message in terms of how healthy is Hamilton, from my perspective, the key message is there are pockets of really unhealthy places here in Hamilton that we need to focus on. But, for sure, if everybody in Hamilton was like Ancaster, we would be a very healthy place.
So I appreciate the answer. I mean, it's a complex question. I grant you that. So asking you if it was reasonable was probably not reasonable. But having said that, the preventative side, my sense of it is that I'm not so sure that the province of Ontario is making the kind of connections that we're trying to connect with here in terms of the anchor institution. So, there's a relationship between preventative care or preventative health care and kind of, I would think, ultimately a reduction in the overall cost of health care, and how that then can get flowed back into preventative health care. So I'm not so sure that we're seeing a cycle here that is providing the kind of benefit that we all want to have happen, which is less patients ending up in the hospital and needing care. So on a kind of a global perspective, do you sense that there's that direction is starting to take hold at the provincial level that's now filtering into communities, or are we're kind of unique in the sense that we're developing this on our own, and hopefully developing a model that the province can say, here's something that can actually be effective when all these institutions are working together?
I think we're at a moment in time, Mr. Chair, through you to the Mayor, where we could take a leadership role in the province by us aggressively coming together and trying to really think of a new model that's more integrated, that, as I was saying earlier, breaks down some of those silos. It would mean it's not easy, because we would need to really open up our budgets and think about different ways in which we were going to pay for all these things. But I do think there's an opportunity for Hamilton to be a leader in the province. I think Hale is really, as I said earlier, it is a start, but we need to, I think, be more aggressive in coming together and thinking about these things, and the city has to be at the table.
Thank you very much. Councillor Jackson.
Thanks, Mr. Deputy Mayor. Rob, where can I ask you about discharge planning? Under this segment, or a future segment, or at the end?
Do you have to ask me about discharge planning?
Yes, I do, President McIsaac, I do. Thank you. Appreciate you being here today, President McIsaac. Thank you.
You can ask me now, Councillor Jackson.
I ask you that now? Thank you.
Mr. Chair.
If you go back to your slide, our vision, the population health approach, that pyramid, please, which showed the high risk, I guess medium, rising risk. Yep. So, quick example, Rob. A few years ago, a constituent of mine, almost 88 years of age, last few months of her life, serious heart issues, diabetic issues, goes into the hospital system, gets discharged by the hospital out to the community. The CCAC comes, looks after. Support isn't really there as much as it could be. PSWs, nurses, once or twice a week, some Meals on Wheels, etc. Obviously aging spouse as well, similar age. And things medically collapse, return back to the hospital system, back and forth like a yo-yo, a tennis ball for about 3 months until she went to be with her Lord. So my point being, I learned during that time in hearing of the family situation that the hospital once had the ability under the Ministry of Health to discharge planning directly to an LTC. But somewhere along the way that was taken away from you and put into the community system under the LHINs and CCACs. Has that been reversed so that you now under exceptional circumstances can discharge plan? Mr. Deputy Mayor, through you.
Well, through you, Chair, we do discharge planning in theory collaboratively with the CCAC. So you're right that by and large that is the system. Two distinct entities, both of whom are supposed to come together to develop a great discharge plan for our patients. It hasn't, and this is not peculiar to Hamilton. I think the experience across the province has been that has not been the easiest system to work with. We are currently involved in a pilot program that was, I'm going to say, initially designed by St. Joe's, where we can follow our patients home with a multidisciplinary care team. So we are currently rolling that out at Hamilton Health Sciences. St. Joe's has been doing it for a while, and it's happening at Joseph Brant and a number of other hospitals. So I think that is an important direction for us, and it's something that we would like to expand out to all of our patients ultimately.
Well, that would be a refreshing change because, to my knowledge, and I'm not trying to drill down onto something, get stuck on this one particular item, Mr. Deputy Mayor, but that would be a refreshing change because over the years I've learned, correct me if I'm wrong, Rob, that the hospital environment handed over a patient to the community under LHINs and CCACs, basically said, you know, you're on your own, all the very best. When that person unfortunately had to come back into the hospital environment, the CCAC said, hospital, she's all yours again. And you see the yo-yo tennis ball scenario, and that person under exceptional circumstances could have been discharged directly to an LTC. So it sounds like you're working on some better collaboration, Rob, and follow-up and cooperation between the community environment and the hospital so that once the patient crosses the border back to the either side, you're not saying closing the file but doing some follow-up? Is that what I'm interpreting?
Yes, that's correct. It's you know, of course, it's a complex thing to describe in its entirety, but essentially, you're right. I mean, I hope what you said on the problem side does not typify every experience, but I would be the first to concede that, and obviously it did happen with the individual you're talking about. So I think from my perspective, the bottom line is we have a kind of siloed system which has admittedly been difficult for us for the patient to get optimal care. We've got a new design, a new model, which we are starting to roll out, which is producing superior results.
That raises my comfort level, Rob. Mr. Deputy Mayor, and lastly, obviously the CCAC situation, with all due respect to all great frontline staff, obviously the collapse of the CCAC with the ministry, Dr. Hoskins' direction, is going to provide a new challenge. So I take it you're at the table with regards to wherever that future might go as well. Mr. Deputy Mayor, through to Rob, maybe for a comment.
Yeah, for sure, Chair. We're vitally interested in that. We did, when patients first came out, which was sort of the thought piece that the ministry and the minister published around that, we did put in a response saying that pretty much along the lines of what you were saying, what the councillor was saying, Chair, that we wanted to have a more direct responsibility to an ability to follow our patients home to make sure that they weren't getting bounced around the way you were talking about.
Thank you very much, Rob. Thanks, Mr. Deputy Mayor.
Thank you. Second time speaker, Councillor Green.
Thank you very much. And it did occur to me, Mr. Deputy Mayor, that at this particular point, this being a special GIC for Hamilton Health Sciences, there, Mr. McIsaac, I'd be remiss if I didn't ask what you thought the city could be doing to help reduce the costs and burdens on Hamilton Health Sciences. What policies or initiatives do you think we should be supporting as a council to help align ourselves with the work that you're doing?
Through Chair, thank you. It's a great question. I think the big issues, Chair, frankly, are, and I think I said this, the poverty of the issues that we're facing. So to the extent that we are collaborating and working together to address those social determinants, it would mean a huge amount for us. I think maybe more specifically, housing is a really big deal when it comes to supportive housing in particular, when it comes to our business. So we know that there are so many people that get into trouble for the simplest of reasons, because they don't have some of the most basic supports in place. And it would be, to have somebody help somebody with some of the simplest things would avoid them having, extensive interactions with very high-priced staff within the hospital. So, and that has been a topic that's come up at Hale quite a lot. How can we think about new housing models for people who require some support? And that is only going to magnify as the population ages. More and more people are going to need more supports. And so that is, I think those would be my top two.
You may be aware of our recent Our Future Hamilton consultation, extensive consultation. I think 50,000+ people contacted, and one of the themes was to create healthy and safe communities. How do you think, in terms of our strategic plan that's coming up, what things can we do aside from the housing that you had just mentioned that might be able to help not just our residents, but even, for instance, some of your staff and the pressures that you guys face that are bricks and mortar?
Yeah, I think, so I'm not, respectfully, Chair, I'm not trying to be ambiguous, but I think the notion that, we have a more collaborative, more active and engaged relationship with each other and thinking about these issues is really for us to be thinking about all of the things that we do that impact on the other, and there's lots. So, I think having a more open approach, a more collaborative, a more regular approach to dealing with community issues would be something we would really welcome, and that could really pay dividends.
Excellent, and certainly can appreciate the broad approach of your answers. And I guess, should there be anything specific from a policy perspective coming out of Hale, I would certainly encourage you guys to delegate again and to provide any insights. I think that there is a role as one of our biggest employers and anchor institutions to play in and around advocacy on policy, and would certainly invite and appreciate that in the upcoming months and years. Thank you very much, and I will retain the additional questions for the further segments.
Thank you. I have no further speakers. So please, Mr. McIsaac, continue.
So I think as we're drawing towards the closing section, just wanted to point out that Hamilton Health Sciences, and Councillor Green provided such a great segue. We are such an important economic generator here within the city, and so that doesn't change in our vision. We are committed to a research agenda that is literally world-class. We are one of the top 2 research hospitals in Canada. $212 million in private funds coming into our research engine in the last year. We are a multinational organization running clinical trials literally around the world. We have 450 researchers who are doing amazing work on a regular basis. Also a teaching institution with over 2,200 students going through our house annually. We're also a service provider for the rest of the province, providing health informatics and other key services like Critical, which is essentially an infrastructure optimization system for the whole province. People call into Hamilton Health Sciences from any hospital anywhere in the province to get referred to appropriate expertise. So all of those things we think set us apart on a provincial level, and we are committed to playing that leadership role provincially going forward. Thinking about our vision in 20 years, well, we want to make sure we continue to apply global research locally faster and better than anyone else in the country. We want to be a national leader in the application of evidence-based medicine, making sure that the quality and appropriateness of the treatment that people get when they come is based on the absolute best standards. We need to continue to be a magnet for the best and brightest, because that's basically who we need to fuel this engine. And we're also thinking lots about strategic innovation alliances with industry. So you saw IBM was an early example of how we think we need to be open to potential collaborations with the private sector in order to really drive forward what we're doing. So very quick section, just a bit of a chance to brag and to tell you that we intend to continue to be a center of excellence for the country.
Thank you very much. Councillor Green.
Thank you very much, Mr. Deputy Mayor. I'm trying to keep all my questions relevant to the sections of the presentation. And I know through you, Mr. Deputy Mayor, the last time you were here, Mr. McIsaac, I extended an invitation into what has now become the Mayor's Intelligence Communities Task Force to look at ways that as a municipality we can create better digital infrastructure to help service some of the innovation that you've outlined here. We now know with IBM. What are the opportunities that you see on the horizon for a growth in this emerging, whether it be pharma, nanotechnologies, kind of the really high-tech sector of healthcare that we could use and leverage as an economic spin-off here in Hamilton?
Well, I think through you, Chair, I think there's a ton of opportunities, and we very much see ourselves as being at the center of that. And so, we are running all these clinical trials around the world, but I think there's more opportunities here at home. Thinking about even better connecting some of the research that's going on at the university to what's happening in our hospital. Different kind of clinical trial, but equally important that we need to think about getting into. And we have made a very deliberate choice about trying to find ways to take ideas that are happening within the hospital and finding out whether or not we can turn them into opportunities. Working with Bay Area Health Trust to make that happen in a way that has not happened previously. So I think this is such a great greenfield opportunity for Hamilton to become a real, even more so than it already is, a real cluster for healthcare innovation. And we'd be very pleased to partner with the city to think about how we could supercharge those efforts. But we are working hard at it already.
Mr. certainly an exciting time, seeing how fast, Moore's Law technology doubling every year. I can't imagine where we're going to be 5 years from now in terms of some of the vast improvements and leaps in technology. So I certainly look forward to that, and again, would invite that at any time, should you, your staff, or members of the anchor institutions, the HAIL group, find or identify gaps, weaknesses in our digital infrastructure and in ways that the city can support that type of innovation, I'd certainly also be happy to help champion that here around council. Thank you.
Thank you, Councillor Green. I have no further speakers. Pardon me, Mayor Fred.
So, thank you, Mr. Chair and Rob. On the IBM piece, can you kind of explain how you see IBM fitting into your kind of health data analysis kind of work? I think for the benefit of all of us, I think it's a great announcement for sure, and I think we understand IBM and its kind of move towards data analytics and all of that great work. But how do you see that partnership evolving?
So I think that the opportunity with big data and cognitive computing really exists. There's a ton of opportunities, but for us, the really exciting part is in the middle part of that triangle, those rising risk patients. And so, we have huge warehouses of data, which we have not been able to look at in terms of mining the intelligence, the intricate correlations that might exist between various pieces of data. And big data, in theory, should allow us with a lot of, previously impossible intelligence to look into those rising risk patients and identify correlations and even individuals who we think we need to reach out to and try to avoid that middle from going into the top of the pyramid. So that's one opportunity. If IBM were here, they would talk a lot about Watson and the capability of Watson to, go out and read literally millions of pages of data and research results and take them all back in and apply them to an individual who happens to be sitting across the office from the doctor. We know that there are lots of things like sepsis, very difficult to diagnose because it looks like all kinds of different things. You kind of wonder whether or not using artificial intelligence, you might be able to get a lot better at catching folks in conditions like that are very difficult to detect today. IBM, their regional VP said to me that for a doctor to maintain currency in a particular specialty today, they should really be reading about 50 hours a week just to keep up with all the new research coming out. So the nature of knowledge is changing, and we need to think about new paradigms for how doctors are going to be able to keep up with so much information that's coming out. And so that's really the area, the space that IBM is they've made some big bets on. They're not the only ones though, GE is, and many others are in the same space thinking hard about how we're going to, what's the future of medicine and how are we going to enable it.
And I appreciate that, and I think added to that then, would it not be useful, since place actually is such an important factor in terms of long-term health care. I mean, we talked about that earlier, depending on where you were at, that civic city data and data around MPAC and the assessment and all the kind of things that come out of that data piece, having that be available as part of the kind of the analytics would be extremely useful. And is that being contemplated, or is that something that we should be contemplating? And how to marry that together to kind of even get more specifically around preventative care?
That's an interesting idea. I hadn't thought about it. I don't know if anybody else on my team had thought about marrying up. No one's jumping to their feet. It's an interesting idea. I think we'd be happy to bring it up with IBM and meet with the city to think about what's the data that the city has? For sure, public health would have some data. I think the other, looking at the telescope through the other end, the city could probably really, in terms of public health, benefit from access to our data too.
Clearly, yeah. I think it's a two-way street for sure. Data, I think, helps us both, I would think.
Yeah.
Okay, I'll explore that. Thank you.
Thank you. I have no further speakers. Mr. Murkowski, did you have one final section?
I do.
Great.
It's the most exciting one too, Mr. Chair. So it's probably worth just pointing out that we have two distinct roles as a hospital. We've probably got hundreds of distinct roles, but for the purpose of this presentation, we do act as a community hospital for Hamilton, which is really critical. But we are also a regional center, providing tertiary care for almost 2.5 million people across the whole of the LHIN and beyond our LHIN. So we've got these regional programs, which are true centers of excellence in stroke, cardiac, and vascular trauma, neuroburn, cancer, and pediatrics. It can be a challenge trying to balance and maintain excellence in both the role as a community hospital and as a tertiary center. But I think we have been maintaining that balance, but it is challenging for us. I think as we look forward on the community side, our vision is really one of more smaller, many different kinds of access points for our community role, through things like urgent and ambulatory clinics, community care delivered in partnership with others, even virtual access points where you should be able to, in theory, access the hospital virtually and have access to some of our services. The funding systems haven't caught up to our vision, but for sure, looking ahead, we need to think about kind of 1,000 points of access into Hamilton Health Sciences. You shouldn't have to show up at the emergency department every time if you want to have access to all of our expertise. So we're thinking hard about how we can become a hospital without walls and get more intimately into the community through things like partnerships and virtual access, even mobile clinics. So thinking about pushing those services out to the extent that we can. Having said that, there are a number of factors that lead us to believe that over the next 20 years we will need probably 50% more space in 20 years than we have today. That's due to a number of things. It's because of population growth. It's because new hospitals are bigger than old hospitals. So everybody tends to have private rooms in new hospitals just because it makes sense for infection control reasons. There's a minimum of 80% private rooms. And accessibility standards also bump out your footprint. So we continue to have rooms that are so small that you cannot get into the bathroom with a wheelchair. And so we need to rethink the way we use space within our hospitals. Just note that we've got several aging buildings that are not well suited to growth or redevelopment. So as facilities reach the end of their useful lives, we have to think about how can we reconstruct this space in addition to growing to meet the changing needs of the population going forward. We intend to focus our growth and redevelopment on 2 campuses moving forward. We think that will both enable efficiencies that we don't currently enjoy, but also benefit our patients in a way that because we'll be able to offer them better service. At the same time as having more community access points, we're proposing to build a new Hamilton in the next 20 years. We're proposing to update the General and Juravinski, redevelop the old wings that currently exist there. We're also proposing to redevelop West Lincoln Memorial Hospital. So, in summary, our vision is really about reimagining our relationship with our patients to be one that's more enduring, about taking a population health approach, which really means that we are going to try hard to reduce people's reliance on hospitals and get further. We intend to continue to be national leaders in research and learning. We are looking for new and innovative partnerships. We think over the next 20 years we will need to rebuild large sections of Hamilton Health Sciences. So there's lots more work to be done. Assuming we get past this stage 1A, we'll begin the next stage of our planning process. We will continue with our engagement of stakeholders, unless there be any doubt, we will remain committed to investing in our current infrastructure to make sure standards are appropriately met. Chair, thanks for your indulgence. That's the last section.
Thank you very much. Councillor Jackson.
Thanks, Mr. Deputy Mayor. Rob, on the slide, our vision for 2036, please. Thanks. New Children's Hospital. So we went through the painful closure of the McMaster Medical Emergency to be exclusively for children. You want to do more than that? Expand on that at that site, different site? Mr. Deputy Mayor, through to Rob for a comment.
Yeah, so I think the likelihood is that it would be a new structure built on the campus of the General.
General, okay. And on that first bullet point, Rob, you talk about 2 campuses. So you talk about 2 campuses, Rob. Earlier slides, you talk about if a service doesn't have to be in a hospital. You say several aging buildings are not well suited to growth. So President McIsaac, you look after hospitals. I don't. We look after here at this table libraries, rec centers, arenas, roads, sidewalks, airports, things like that. And so in your former life, President McIsaac, you understand fully the sensitivities at this table, and you don't even have to comment in my closing comment. But I just gather that you're trying to, in your best, wonderful, diplomatic, sensitive, thoughtful way, prepare both us and, more importantly, the community that there's going to be some serious changes down the road. And it may lead to hypothetical reallocation, consolidation, possible closure. And I just leave you with the thought from your former life that once you pluck that library, that rec center, that school out of that community, out of that neighborhood, it's like a hub. It's often then gone forever once closed or consolidated elsewhere, and causes a lot of anguish and pain. And I think we got a darn good system. People fly in from all over the province. I know friends from Thunder Bay that come here for our great cardio care at the General. But I'm rambling right now, but I'm just sharing with you where my intuition's going, where I sense you've tried to be very calm and careful, where your ultimate direction may be leading our community. And I just tell you that as much as possible, if hypothetically, that's where you're going, Mr. Deputy Mayor, have lots of consultation, not just within your industry and within more or less the elite of who would provide the innovation and the management changes, but with the grassroots and the community at large, because we've been through this before and it was extremely painful and difficult. And sometimes decisions were reversed because of the backlash and that. So thanks, Mr. Deputy Mayor. Thank you, Rob, for being here. No need to comment unless you wish to. Thank you.
Chair, I just say, just to be clear, we are not proposing to close any programs. In fact, we're looking at building at the end of this, we'll have 1.5 times the footprint we currently have in the community. And I think a new women and children's hospital is something that Hamilton ought to be excited about looking forward. So I think this is a good news story, but it doesn't mean, you're right, it doesn't mean that there won't be any change. We're proposing that we would have fewer big, huge campuses. but we would have many more points of access into the hospital going forward. So I think on the community side, you will see more access points, more local points for people to feel they can get into Hamilton Health Sciences. For those big regional services serving 2.5 million people, there will probably be a combination or a focus on 2 new sites, Juravinski and General, for regional services. And you're right, people do have to fly in from all over the province to access them. For people here in Hamilton, they might have to drive a few more kilometers to access those regional services. But, I think we are so lucky to have those regional services. When you think about people having to fly here all the way from Thunder Bay and not complaining about it because they can't have those in their local community, it does put into perspective the notion that if, we were to move and rebuild into brand new space, bigger, better space, 3 or 4 kilometers down the road, it puts those concerns into context from my perspective.
Thank you. Councillor Farr.
Thank you, Mr. McIsaac, for the presentation. I listened with interest and heard some pretty good questions as well as we progressed here this afternoon. Just heard you talk of General Hospital and a potential expansion there. I'm wondering if you could expand on that. When, if that will occur through you.
I think it will be modestly, 15 to 20 years from now.
A lot going on already in that precinct, and all great stuff, but you piqued my curiosity. So 15 to 20 out, I'll look forward to that with giddy anticipation. The comment about facilities, I don't remember the slide, but it said several aging buildings are not well suited for growth or redevelopment. Just from the planning and economic development side of things, where will we be able to assist in terms of zoning? When did those conversations start? If there was an inability for you with most of your current facilities to build up, then you're talking about building out near these facilities, and therefore are these questions that you've already asked of our general manager of planning and our planning staff or any of the Hale folks, or is that for future as well?
I think so. We've definitely been socializing these themes, but it is so far away, and we haven't yet even gotten through the very first phase of our process yet that we haven't really done any, pre-consults on zoning and those sorts of things. I think as we get closer to at least some preliminary approvals, we could start those conversations with the city. But it's, again, just important to point out where this is very long-range planning.
And finally, when you talk about, through you, Chair, getting out to the community more, which is admirable, and I think something that it's already proven to be pretty successful. So growing that initiative is more than helpful for a lot of people, obviously. I always think of 2 things, and you've been talking about this for a while now. Dr. Morrison, who used to do house calls to the Farr family and thousands of others from his James Street South office. When we were feeling too ill to go to him, he'd come to us. And then more recently, clinics like the Rosedale Medical Clinic, which was very much supported, as I recall, many years ago by the provincial government, and that sort of concept was endorsed. You're obviously not talking about doctors making house calls again, although from the technology standpoint, more and more we are seeing that already. But are you more talking then about the medical clinic that the provincial government has been for some time endorsing, almost like these mini hospitals in communities?
So I think we're open to evasive here. I think there's things that need to happen that we haven't even imagined yet. And so that's why we keep talking at a principled level that we're looking for partnerships with others who can help us to create a healthier population. And so, The Y is a great example of something we're doing today where we've got pre-habilitation and rehabilitation programs. People can go to the Y with a program that has been designed in consultation with us and with McMaster before their surgery, and then get direct admission back to the Y after surgery that helps improve outcomes all the way around. So that's a great example, but we are open to all kinds of other potential partnerships where we can be out in the community, either for sure, as you said, it could be directly with ambulatory control and run, or it could be somebody else like the YMCA who is delivering a service but comes to us and says, you know what, if we got together, we could do a lot more together than we're currently doing apart. So Catholic Family Services, another great example of civil society that we've partnered with that's doing great work for us, helping to keep people out of hospital, providing supports for people in the community. So I guess I'm saying, listen, we're opening the door to partnering with a broad array of civil society to try to take a much more collaborative approach to creating a healthier community here in Hamilton, and that the days of us simply waiting to see who shows up, treating them and discharging them and not worrying about them until they show up again, those days have got to start. They've got to be gone because we can't afford that system anymore.
Final question through you, Chair. Are there other communities doing similar visionary work that you're aware of?
Well, none as well as this community. I'm sure there are. I think that Niagara has gone through a similar process, although I haven't been as intimately involved there. But as I started out the day by saying, Chair, this is a standard process at the ministry, but I will say, just to brag a little bit, I know I was kidding before, but the people who have been helping us with this have consistently said that we have raised the bar for the kind of consultation and visioning that's gone on here. So I'm not aware of anyone else who's done it quite like we're doing it.
Fabulous. I see no further speakers. So thank you.
Thank you, Chair, and thanks, councillors, very much for the time. We appreciate it very much, and lots of good advice, which we will heed.
May I please have a motion to receive the presentation? Councillor Vanderbeek, Councillor Pearson, all in favor? Great. Any notices of motion? Seeing none, may I please have a motion to adjourn? Thank you, Councillor Green and Councillor Jackson. All in favor? All in favor? Meeting adjourned. The rules say we can gavel at the beginning and at the end.
Thanks, Jason. Okay, thanks.
I think the transportation policy, active transportation policy, mass transit, get your employees to and from the hospital.
I think transportation is one of the, from my perspective, it's one of the few areas of the environment simultaneously, right? Like it impacts all three pillars of sustainability, which is one of the so, and if I can help on the LRT side.
Great job, Rob. Thank you.
Thanks, Mayor.
Okay.
Good to see you.
Actually,
Thanks for the
we
invitation.
should talk about the idea.
Let me just go around to the
Yeah, it's always hot.